Hello, and welcome to Understanding the Role of Resilience in Gender and Sexual Minority Communities. All participants are muted and unable to turn on their microphones. Today's session is being recorded. The slides and recording will be sent out to all participants within 5 business days. We do not offer CEUs. You can receive a certificate of attendance by following the link emailed with the materials. Please use the chat box or the Q&A function for any questions. Also, please call out where you're viewing from in the chat box. When using the chat box, make sure your message is set to the correct audience, either panelists only or general. Today's presenter is Kristen Krause. She is an adjunct faculty member at the Rutgers University School of Public Health and the Deputy Director for the Center for Health, Identity, Behavior, and Prevention Studies, a leading training ground for LGBTQ scholars. She has expertise in HIV/AIDS, aging, resilience, and broader LGBTQ health disparities. More specifically, her work examines resilience as it relates to biological, psychosocial, and psychological and social health states among older gay HIV-positive men. Previously, she was the recipient of a T1 Pre-doctoral fellowship at the Clinical and Translational Sciences Institute at NYU Langone Health, and more recently received the Stuart D. Excellence in Research Award for her dissertation work from Rutgers University School of Public Health. More recently, she has spent her quarantine days cooking away more than she ever knew she could and spending a lot of quality time with her cats, Mandela and Hamilton. With that, I'm going to hand it over to Kristen.
Good afternoon, everyone. It's such a privilege to be here. Thank you so much to Madeline for inviting me to be here this afternoon with everyone. We're in very strange, unprecedented times for a multitude of reasons. And, one of the things that I've really been learning throughout, my coursework and throughout the early stages of my career is how resilient people are and people can be in the face of adversity and challenges. And I think now more than ever, we can kind of tap into, some of that learning and hopefully come out on the other side of this whenever it is over, stronger and better than we came into it, even though it often doesn't feel like that on a day-to-day. So I'm really, as I mentioned, really happy to be here this afternoon. I'm trying to figure out the screen control. Where is it going? Sorry, everyone. So today I'm really hoping that we can talk about some of the overarching healthcare challenges that sexual and gender minority, also known as LGBTQ people, face, with a particular focus on older HIV-positive gay men. This is a lot of what I'm presenting today, direct results from my dissertation that I defended about 6 months ago now, which is kind of crazy. I literally defended the day before the national shutdown on March 12th. So this was the last in-person thing I got to do was my doctoral defense. But really, kind of understanding what some of these challenges are and figuring out how resilience, describing it first off, and also how it can mitigate the impact of some of these biopsychosocial health outcomes in the different communities that we work with, specifically sexual and gender minority individuals, and really kind of figuring out how this can also relate to coping with stigma and discrimination for these communities as well. So just to kind of get us started on an even playing field, there's been a lot of evolution and transformation over the past, several decades when it comes to language on LGBTQ individuals. I will be switching between LGBTQ and sexual gender and sexual minority throughout this. And so this I'm not going to go through each one, but this kind of very colorful representation kind of shows what the many different letters under this wide acronym that we have of LGBTQ plus mean. So, we've got lesbian, gay, bisexual, transgender, queer, intersex, ally, asexual, pansexual. There's many of these different terms. These slides will be available for you all after the fact, so you'll have this resource as well. But we've come a long way. The one thing that I do want to make a clear distinction about for everyone is that sexual orientation and gender identity are not the same thing. Sexual orientation refers to attractionality. So when we hear the terms lesbian, gay, bisexual, pansexual, asexual even, this is what would fall under that particular part of this. But gender identity really refers to how someone expresses their gender. Gender is different than sex assigned at birth. And so just is while we're often put under the same umbrella for research purposes, one of the arguments I will make throughout this presentation is that it's not enough just to say like, oh great, we're starting to do way more research with the LGBTQ community. That's fantastic and absolutely needs to continue moving forward. But the health and well-being of lesbians are much different than the health and well-being of gay men, is different than bisexual people, is different than transgender individuals. And even within each of these communities, when we think about intersectionality, whether that's race, ethnicity, whether that's socioeconomic status, geography, the health access that folks have in more urban communities throughout the US is much different than those in rural communities. The pandemic presents an interesting perspective on this, because we're seeing an increase in telemedicine and what that looks like, which has my brain kind of percolating in the future on how we can get services scaled up to folks who may not be able to access them as easily, especially in person. So, as we move forward, thinking about this, I just want to make sure that we do understand that sexual orientation and gender identity are very distinct ideas. And so when we're talking about LGBTQ people overall, it's very difficult to put an accurate estimate. As many of you may or may not know, the US Census, which is one of our main national tools for counting data, does not include questions on sexual orientation. And the questions that kind of ascertain gender identity and sex assigned at birth are not written well at all. So it's very difficult to understand it's hard to actually estimate how many people in the US identify as something underneath the LGBTQ sexual and gender minority umbrella. If we can kind of put some of this together based on some of the other national research studies that exist, BRIFIS, NHANES, some of these things have these questions in them. But, one of the problems that researchers who focus on SGM populations face is that we're often trying to kind of piece together these multiple data sets to try to, inform some type of larger number. So right now we're kind of at 11 million. Again, that needs to be taken with a grain of salt, but we need much, much better ways of tracking that data. And I see someone in the chat mention that that there is a question on same-sex households, which is definitely a step in the right direction. And is often utilized as a proxy for some of this data. But for those who do not live in a same-sex household, they would not be counted under that. And other estimates, we've seen that 19 million people have engaged in some type of same-sex sexual behavior in the past, and almost 25.6 million people have acknowledged same-sex attraction. And so, one of the things that I do think we are starting to see is that many issues and and conversations around sexual orientation and gender identity are moving away from this boxed approach to needing to fit into one identity or another, and looking at things more on a spectrum or on a continuum, which we know is very common in but not widely discussed and not widely researched. So the other, I just want to make sure I'm using the right. So the one thing that I want to do today is, I know that this is a mental health specific webinar, and I'm definitely going to be highlighting some of those challenges within these communities. But I do want to make sure that we acknowledge that that when we're thinking about health overall, it's important to ensure that we're talking about a holistic perspective on health. So this is kind of where I bring in the biopsychosocial perspective. So understanding that your mental health is in synergy with your psychosocial well-being. So things like loneliness and stigma, and kind of how that can impact your relationships, your physical health. All of these things kind of require a certain level of synergy that can't exist, at one time or another. So, obviously we've come, I don't want to say a long way. I feel like that's an over exaggeration, but more recently we have seen more honest and open conversations around folks talking about mental health and mental health struggles and challenges, and also mental health wins and treatment options and all of that kind of stuff. But we need to do a much better job of being able to talk about that from a more holistic health perspective as well. And so one of the other things to think about is that when we talk about many different health conditions, whether it's depression, whether it's HIV, whether it's cardiovascular disease, many of these conditions do not exist in isolation. And often they're mutually reinforcing to each other and with one another. So we call this a syndemic approach. And so, thinking about how, again, similar to what I just said, thinking about how our mental health interacts with, how depression can interact with an HIV diagnosis, can interact with cardiovascular disease. All of these different things interplay with one another, and that impacts the overall health conditions that a person may face. And so, we've kind of we've come a better way more recently as well when we think about researching LGBTQ populations. But we still have a great deal to learn. In 2000, I think it was about 2008 or 2009, when the administration at the time put out a call for learning more about LGBTQ populations. Through this kind of call came the Institute of Medicine's, which you see the book cover here, their research report on the health of LGBT people, and kind of building a foundation for better understanding. And so this was, like I said, a step in the right direction. It's definitely served as the catalyst for many studies and many initiatives that have come since then. But it's hard to believe, as we say this out loud, that this report came out in 2011 and we're already almost in 2021. So a lot of this data that we are looking at from this report is nearly 10 to 15 years old at this point. And so, with the rapid change of technology, with different health interventions, even around, HIV, which is often associated with the LGBTQ community, and we'll talk about that momentarily, but a lot of things have changed, and in some aspects, research has expanded in many of these areas, but there are still many, many, many areas that are under-researched and underfunded. Funding is a huge barrier that researchers and community activists and folks face when it comes to understanding what some of these issues are. So when we do think about a research agenda, we can think about several different approaches looking at minority stress. So again, as I mentioned before, the health needs and health outcomes for lesbian women may be different than gay men, are different than trans women, are different than trans men, are different than gender non-binary folks, are different than bisexual folks. And so thinking about how these intersecting identities impact and work with one another from a minority stress perspective and a minority stress theory is important. Looking at how these things change over the life course. So there might be certain things that are more pertinent and come to be more impactful at an earlier stage in life compared to later. And really understanding how our social relationships, our communities, we're in, without belaboring the point, we're in a strange time right now, and a lot of people have lost their physical spaces to connect with other LGBTQ folks because of the pandemic. So, finding online spaces, finding, support groups that might be happening over Skype or over the telephone, figuring out how to navigate this in a physically, I don't like the word social distance, but a physically distanced world right now is quite challenging for many people of this community. And the current, I will not make this very political and I will not stay on this for too long, but the current administration has put forth many stigmatizing, detrimental policies, specifically more so geared at the trans non-binary communities in the country. There are many structural level issues here, but when we start allowing religious freedom to be an excuse to not care for people, we're heading down a very, very dangerous path. And all I can say on that right now is to vote on November 3rd. It's not just, trans folks in the military. There's many different issues around economic inequity, housing inequities within the community, within different racial segments of the community. And so, we have it felt like we took many steps forward, and then a lot of what the current administration has done has felt like many steps back. But luckily our community is resilient, and that will kind of be the takeaway hopefully from today. So to kind of keep us moving forward, when we think about physical health disparities, and this particular slide is focused more on lesbian, gay, and bisexual individuals, so sexual orientation. We see lower levels of overall self-rated health, lower, younger age of disability onset. So, notice or having a disability earlier in life. Gay men in particular, higher levels of gay bisexual men, higher levels of acute health conditions, cardiovascular disease, urinary incontinence, cancer diagnosis, which is also correlated with lower cancer survival rates. And in lesbian and bisexual women, we see again overall lower rates of self-rated physical health, and higher levels of risk for invasive breast cancer, cardiovascular disease, hepatitis. Among trans folks in particular, we see different challenges involving hormone use in terms of blood pressure, blood sugar, blood clotting. That's not the case across the board. I feel like I've often seen hormone use be used almost as a crutch of what people say causes health problems, and that's just not the case. What needs to happen is better education for medical providers and more holistic education for medical providers especially those who are prescribing hormones, that, you know, they're not just looking at the endocrine system, but they're also looking at how the different systems within our bodies function together. But among trans folks, we also see, you know, increased rates of substance use, including all types of alcohol, tobacco, and other drugs, higher rates of depression, anxiety, and pretty high rates of sexually transmitted infections, including HIV, with a rate of 14.1 among trans women, 14.1%, sorry, among trans women, and 3.2 among trans men. The other thing I would like to point out when it comes to HIV is not something I'm going to focus on a lot today, but trans men are often, more often than not, excluded from these conversations when it comes to gay, bisexual, and other MSM. And that's something that researchers need to be aware of and do a much better job at ensuring that trans men are included in studies when it's looking at HIV risk. Other mental health disparities that we see in the community, we see that lesbian, gay, and bisexual individuals have higher levels, higher prevalence of various psychiatric disorders within the past 12 months. So these include mood disorders, anxiety, substance use, and, you know, many of these different things that I have just mentioned, again, all kind of interact synergistically with one another. You know, there's many different drivers of healthcare disparities. We've got, you know, obviously personal level factors, experiences of stigma, you know, things that we can't totally change about ourselves, race, ethnicity, our socioeconomic status, level of education. And, you know, there's been a lot of focus on these personal level factors, especially in public health research. And I would also argue in psychology research. And one of the things that we really need to move towards is understanding how we can impact and change the structural issues that are so pervasive in many of these health issues. Structural stigma, clearly structural racism, institutionalized racism, gun violence, provider training and education. You'd be, you know, not surprised, but, you know, medical doctors, nurses, dentists, they're not receiving across the board any type of specialized training in working with LGBTQ people. And if they are, it's often a short 4-hour training, you know, on a Friday afternoon that may or may not be optional. There's many different groups, advocacy groups, working to kind of mitigate this moving forward, but it's still it's not a perfect system at all. And so with that, there's been this recent, I would say within the last 10 to 15 years, push towards, you know, understanding, as I just mentioned, we know what some of these barriers are, we know what some of the issues are. How do we move past them? How do we, like, especially in public health, we really do like to focus on risk a lot. We like to focus on the doom and gloom, as I like to say, but, you know, psychology and social work have done a fairly good job over the last several decades of also looking at things from a positive psychology approach, a strengths-based approach, and that really comes from the form of resilience. And so we're starting to see this a lot pop up in different modalities, especially within the LGBTQ community. GLSEN put out a fantastic report within the last few months, actually. You can go to their website and get it, where it talks about experiences of LGBTQ students of color. And I know within what GLSEN offers, they have, it's not just one report, they have several different reports. And I'm really proud to say that I used to work with one of the people who led that initiative, and to know that someone led it who's so deeply entrenched in this work and cares about it on a personal level just makes it, that much more meaningful. And so I'm throwing this resilience word around, and I'd like to kind of expand a little bit more on, what I mean by this. And so there's not an agreed upon definition of resilience. That American Psychological Association will say it's a process of adapting well in the face of adversity, trauma, tragedy, threats, or significant sources of stress. Other broad definitions include a capacity to thrive in the face of adversity, coping successfully with significant change. Simply put, I like to refer to resilience as the ability to bounce back and overcome challenging situations. These challenging situations can be, many different things depending on what type of framework you're thinking about and what lens you're using. And so, as I mentioned before, a lot of my work has been looking at older HIV positive gay men, and I'll talk a little bit about why gay men specifically, but living through the HIV epidemic and aging with HIV is a challenging situation. And now many of these folks are living through another pandemic in the time of COVID. And so we have a lot to learn from communities like this, and not just older gay men, but that's the starting point that I have been navigating. And so, sorry, I don't know what's happening with the computer. So when we think about resilience, it's not the part of the reason why there's a few different, why there's some disagreement or there's just not a general consensus is because, in some aspects, people, researchers and community leaders think of resilience as being a trait. It's just something that people have. It's something that they're born with potentially, where others view it as a process, something almost like a muscle that can be strengthened and practiced over time. And there's been more recent literature considering resilience as an outcome. And so this figure actually kind of shows most of these processes, most of these domains at once. But it's really resilience started. Research around resilience started in children, and so that was in the 50s, 60s, and so we're now getting to the point where we are looking at this more from a life course perspective. We're looking at research. Researchers are doing a lot more work in adults, especially older adults, and so there's still a lot that we are learning through this. But the one thing I know, or that I will argue, is that it's an important tool when trying to figure out how a lot of interventions, especially in public health, have tried to figure out how to get people to stop doing something, or focus on health behavior change, which is fine and definitely needed. But we don't do a great job of focusing on how to tap into things that people are already doing well. What types of strategies are they already employing to overcome different challenges, and how can we scale interventions both at an individual level but also a community level in order to do that. And so there is a growing field of research around community resilience and what that looks like, both from a geographical standpoint, but also even things like the LGBTQ community as well. Unfortunately, not a ton of that has been done in the US. There's been a decent amount of work coming out of Australia, especially around collective resilience among gay men and other sexual minority men. But I'm hoping that more of that work will catch on here as well. And so there's a few different ways of measuring resilience. As I've mentioned, that with lack of understanding on exactly what it is or consensus, there's many different ways to measure it. And so a lot of these efforts have focused on, more innate individual perspectives, positive emotional resources, hope, optimism. Some have looked at it from more of a interpersonal relationships, social ties, and then also a community level that I just kind of mentioned, engaging in, not just the natural environment, but how do resilient people have satisfying work-life balance? So there's been many, many different approaches. Some of these scales that I've listed are the most common quantitative measures, but there's also been many qualitative investigations into resilience as well, to kind of understand from an individual level, what does it mean. I've done some of that work limitedly in the Newark metropolitan area with older HIV positive adults, not gay men, just adults in general, trying to understand what their thoughts around resilience are. And it was we're still analyzing the data, but it's been a pretty, mixed bag of, I just do what I have to do and I keep moving forward. Which, to me has been kind of interesting in terms of relating it to other aspects of health. So, some people see resilience as being able to take all of their medications, or being able to go to their doctor's appointments, or asking for help if they need it on something. So, this is still also quite a developing field as well. And so to kind of highlight a little bit more around resilience among sexual gender minority communities, there's a wide range of factors that contribute to resilience in these populations. Some of what I just mentioned on the individual level, having a higher, way of self-efficacy, higher cognitive ability to mediate stress, proactive coping, self-care. And some of these things people have learned just by navigating different stigmatizing situations, different adversities that they faced, potentially at home, within their schools, within their communities. And so, we're still trying to understand a lot of what may make someone more resilient than someone else. A lot of that has been still untapped, but knowing that these things are contributors is definitely an important starting point. And then when we think about, community and environmental, having, social support, having positive LGBTQ role models, representation of, folks in the media, on TV and movies, and having those, overall connections, which again, I think, in the time that we're in right now, when we think of connections and social support, it's challenging because so many of us are physically not able to congregate or be together in ways that may be most ideal. So, some of us still might be very active in protests and in gatherings and in vigils, attending smaller community-based events. But right now it's challenging for a lot of folks to do that in the current landscape. And so there was a study done in 2003 that was really looking at what some of these resilience factors might be. And so I present two tables here and to kind of just go over them really quickly. But some of the main stressors that they noted were encounters with homophobia, community divisions, internalized homophobia, understanding what sense of danger, and again contextualizing that this work was done in 2003, so again almost 20 years ago. We could argue that some things have changed, not everything has changed, but the conversations around LGBT issues and have changed substantially over the last 20 years. in some regards, not, we're definitely not where we need to be. But when we think about resilience, um, having a movement perspective, meaning, being able to advocate for yourself, advocate for community, confronting internalized homophobia, so identifying strategies that help overcome these things, and having, overall affinity within the LGBT community was also particularly important. So again, coming back to that social support, um, and understanding. And so one of the things I wanted to do today was kind of highlight a little bit of the work that I've done specifically with older HIV positive gay men. And I say this in this way, and I kind of mentioned it earlier. So, when we were conceptualizing this study, a lot of the work that my mentors had done previously involved older HIV positive, gay, bisexual, other MSM. But understanding that sexual orientation has a very distinct meaning, identifying as gay, again, is different than identifying as bisexual or identifying as a straight man who has sex with other men. And so when we're thinking about coping strategies, when we're thinking about resilience and thinking about how these different things interact with one another, we were very cognizant to build study, specifically recruiting older HIV positive gay men. So one of the inclusion criteria were that participants needed to identify currently identify as male, sex assigned at birth was male, currently identify as man, and identify as gay. And that's definitely not to say that any other identities are not important, but this was one step in the direction that we were taking to show that not putting all of us under this massive LGBTQ umbrella all the time, understanding what the differences are within these groups is also very important. And so that was kind of the goal of this study. And so just, quick background, and I'm actually I don't, if anyone knew that GMHC was hosting an HIV aging webinar today. We have already surpassed the number of people. More people at this point in time are over the age of 50 in terms of the HIV epidemic here in the US. And so the HIV epidemic is graying, it is aging. And with that, there's many different biopsychosocial health stressors that folks aging with HIV face. So just living with HIV in general, the overall aging process of getting older and what that means both biologically and psychologically, and quite frankly, what the long-term impact and implications of antiretroviral treatments are. And so, for those who may not know, antiretroviral treatments were introduced in around 1996 and have been the reason why so many people have been able to age successfully, successfully being a very broad word here, with HIV. Why they're still living, they're still they're still here, and they're great. I, as someone who has a close family member with HIV, I love antiretrovirals, but there's still a lot that we don't know about them. At their core, they're very toxic medications that kill the HIV virus and keep it maintained for people. But we don't know what that impact is long term on the body. We don't know how that manifests itself, especially when we're thinking about other comorbidities that older HIV folks often are living with. And so, as I mentioned, a lot of the times when we've been, working with older HIV positive people, we've been focusing on like what have they been doing badly, or don't like have sex with condoms or any of that kind of stuff, and we're not really focusing on what folks are doing well. And so, as I mentioned, when we think about resilience and we think about HIV, very, very few studies to date have focused specifically on HIV positive gay men. That's not to say that there hasn't been work done on gay, bisexual, and other MSM, but when I make the argument on identity, it's important to, show that that's different. And so this is just kind of a visual representation. I believe this is as of 2016, the CDC estimate. Yep. The CDC estimates of people diagnosed with HIV. And so as we can see in the tealish colors, towards the right side of the screen, we're going to start to see those numbers become increasingly higher as we continue to move forward with the epidemic. And so, with that, people living with HIV are living longer lives, but with that, there's additional challenges. There's heightened health concerns, mental health, especially depression, PTSD, substance use disorders, anxiety. There's many different neurocognitive health challenges to take into consideration. Different, pain levels of pain, coordination, language, memory. I've already mentioned the long-term effects of antiretroviral treatment, ongoing trauma related to HIV, which one may have made an argument that folks have managed up until the pandemic, but I'll be very interested to see what some of the research on this community looks like after, because what's happening right now with COVID is re-traumatizing a lot of people, especially folks who live in some of the larger epicenters of what used to be HIV. So New York City, LA, San Francisco, a lot of folks who have been in these areas for a long time are seeing what's happening with COVID in these big cities, and some of this has been quite re-traumatizing for them. And then when we think about just overall stigma, we think about the fact that older people in general are stigmatized. There's still a lot of HIV-related stigma and misinformation and mistrust. And then, you couple together all of the other identities, race, ethnicity, SES, gender, etc. And one of the other things to take into consideration is that especially many older adults in general, not just folks living with HIV, but in general have fragmented social networks. They're a lot smaller. They may have faced a lot more loss of friends and family as they age, but for older people living with HIV, this is particularly salient, thinking about how many people we lost during the AIDS epidemic, especially in the 80s and 90s. A lot of these people lost lovers, they lost partners, they lost friends, they lost community members, and a lot of the time they didn't even know. They would just show up at the next ACT UP meeting, and you'd be able to make eye contact with someone and about someone else, and that's how they would find out. And so, when we think about this community in general, we really need to make sure that we're attending not just to HIV. A lot of the focus historically has been on the biological management of HIV, which we've gotten, fine with. It's not perfect, but we've gotten a lot better. But we haven't really, been great at attending to the whole biopsychosocial health and well-being of this older generation. And so some of the other, psychosocial challenges that we know folks have actively been facing: anger, fear, loss of hope, loneliness, frustration, survivor's guilt, even like under trying to grapple with, why am I still here, but my partner or my best friend isn't. And keeping in mind that it often wasn't folks just losing one person. Folks were losing many, many people in their communities. And so when we think about mental health specifically, and this is more broadly for mental health and HIV, but National estimates show that, over 15% of adults over 50 have some type of mental illness, and that prevalence is higher for people living with HIV. There was a systematic review done a couple years ago looking at comorbid PTSD and HIV specifically in HIV positive women, and it was found that this group had 5 times the PTSD prevalence compared to the general population. And something similar to my knowledge to date has not been done in HIV positive gay men, but I would estimate that those numbers are similar, if not higher. And we also see anxiety and depression being very common in this community. And so, why does this matter? And so, coming back to this biopsychosocial approach, diminished psychological health has the ability to compromise overall health and well-being. It interferes with consistent access to care. Many who meet the screening criteria don't often receive the mental health treatment that they may need for various issues, whether it's due to insurance or due to stigma or due to accessibility, whatever. There's many different factors. And we've also seen that, depression, trauma, chronic stress are associated with higher levels of viral load and lower CD4 counts. And so, especially when we think about initiatives like ending the epidemic, which, I'm not going to touch on too much, but national and statewide initiatives to, eventually end the epidemic, but also, curtail it as much as possible, which is possible given the fact that we have advances with undetectable equals untransmittable. So, pre-exposure prophylaxis, post-exposure prophylaxis, but it gets very challenging because a lot of these conversations are leaving people living with HIV out of them. And so when we're trying to make sure that the epidemic is maintained or we're trying to reduce it, that also means that folks living with HIV need to be part of these conversations. There needs to make sure that folks are able to stay on their HIV medication, that they're able to remain adherent, because if not, then the likelihood that someone might be able to HIV positive person who has a detectable viral load would then have the ability to transmit the virus to someone who is HIV negative, whereas someone who has an undetectable viral load, so you cannot detect HIV in their system, the likelihood of them transmitting the virus to someone who is HIV negative is as close to zero as you can get. So when we think about resilience in older gay men living with HIV, it comes back to this importance of acknowledging that sexual identity is a key element in people's lives. Examining the construct is not understanding that, again, identifying as gay and not something else on the sexual orientation spectrum is important. Few studies have looked at it at this point, and understanding what this looks like will not only help us confirm hypotheses that we have been putting out into the world, but it can also help healthcare providers build their delivery of care. And understanding that, accepting to understand the buffering effects that resilience might have. And by this, I mean, and I'll show a slide in a minute, but we're basically suggesting that having resilience or being resilient can basically mitigate the negative impact of different biopsychosocial health stressors. And so this image here kind of shows this. So some of the things I mentioned more towards the middle: HIV therapy, the aging process, psychosocial and structural states. What this image is basically showing is that taking these three big things together, that a resilience process can help buffer the impact of negative physical, social, and mental health stressors among people aging with HIV. And so I'm going to go through this a little bit quickly because I want to make sure there's time for questions and get to my final points. But this is just presenting an overview of the study. So we had 250 gay men in the New York City area. We use various recruitment techniques. So, community-based outreach, looking at the dating and mobile apps. And so the main thing I'm going to focus on today is our mental health outcomes from the study that we did. But we examined PTSD and different aspects of the mini International Neuropsychiatric Interview. So major depression, suicidality, alcohol, substance use, and generalized anxiety. And the big part of my dissertation that's not included in here is that I actually created a different scale of looking at HIV and resilience. So I created what is now called the HIV related resilience scale. These are some of the items included. It was piloted within members of this community, but based on some of the other scales that existed, with an argument that possibly creating a more nuanced way of looking at resilience among this community could help, impact some of the findings and some of the service delivery recommendations long term. And so this is just an overview of our sample. It was very racially, educationally, and socioeconomically diverse. The median age was 56 years old. And we interviewed people who were between the ages of 50 and 69. I believe 1992 was the year of median HIV diagnosis. And an important point to note here that 82% of our sample reported an undetectable viral load. And so, that's considerably higher than what we see some of the national estimates being. There's very likely a bias being in New York City, especially given, the outreach that the New York City Department of Health has done around maintaining the Ending the Epidemic initiative. But, just some interesting findings that we had from there. And so what I really wanted to do, and I'm going to just kind of skip over this a little bit, and, I'll explain this quickly, but I think this is the most important. So when we look at HIV related resilience, there was kind of the full scale, but then there were also 3 subscales that came of this. There was an adaptive coping subscale, effective coping, and optimism. And so what we saw at the bivariate level, so when we were comparing resilience to PTSD to depression, we saw that there were significant relationships, meaning that folks who had higher levels of resilience scored lower, or had lower indications of different mental health burdens, so depression, suicidality, substance dependence, etc. And then I'm going to just gloss over this quickly because it's a very big table. But basically, when we put all of these things into one big linear regression model, what we found is that those with higher levels of HIV-related resilience were more financially secure and had lower levels of PTSD. That was also similar to those scoring higher on the optimism and adaptive coping subskills. They were less likely to endorse substance dependence. And there was also, I don't know if it's here, I think it might have gotten cut off somehow when we did the translation, but I also looked at I did a mediation analysis looking at whether or not HIV resilience would basically mediate the impact of HIV related stigma on mental health outcomes. And what we found is that it did, at least partially. So those who had higher levels of HIV related resilience had lower levels of HIV stigma, or had lower levels of mental health, but it was also those who had resilience had lower levels of stigma as well. And so some of the limitations being in New York City, definitely not justifiable to all parts of the US. and the sample was not necessarily, again, representative of all gay men living in the US. We can't make any causal inferences just because this was a one-time study. But some of the future directions that I just kind of want to get us to, and so in public health especially, shifting away from this deficits-based approach to a strengths-based approach. We've seen other domains do this really well, so social workers, psychologists, and then really kind of, tapping into resilience as an underutilized approach. And we're still trying to figure out what that looks like. How do we capitalize on things that people are doing well, or how do we capitalize on a positive mindset? And that comes with also, bridging the gap between health of populations and individuals. Healthcare services for older sexual and gender minorities are very limited. SAGE, which is the Services and Advocacy for GLBT Elders, is a great resource, and they definitely help bridge this gap across the US. But one organization cannot be responsible for all older SGM in the country. We also, I was just on a webinar earlier that was talking about the fact that, again, just taking into consideration that we don't do a great job of promoting sexual health among older adults. We don't do a great job of talking about mental health at any point across the lifespan, but in particular among older adults in these communities. And so a lot more work needs to be done on that. And then, figuring out, so one of the outcomes I was hoping to get from this presentation is experiencing stigma. I'm still very interested in moving forward on how can we tap into resilience to mitigate the impact of stigma? How can we help people build resilience? Because stigmatizing experiences, especially within GSM communities, are not going away, especially under the current administration. But if we can help, folks identify strategies that can, make the stigmatizing experiences a little less burdensome on overall health, that's a great step in the direction. Ensuring that all people living with HIV are included in ending the HIV epidemic initiatives is critically important. Again, prevention is a huge focus, and that's obviously important, but we cannot ignore folks who have already been living with this for 5 minutes or 25 years. Untangling LGBTQ health, I think I've already made this point, but understanding that each group is different. The needs of trans HIV positive women are different than the needs of older HIV positive gay men. Same with bisexual or with straight men, having sex with men. And, to be honest, we don't really know what the impact of COVID is going to be. And this is something that I'm very, very interested in. I have a particular interest in talking with especially older gay men, but, older folks who lived through the epidemic, who are now navigating COVID. What strategies are they employing? Are they, we haven't seen super high levels of COVID among HIV positive people. And so there's a lot of questions about that. And so, again, it's still very early to be able to make any of those, assertions. But these are just some resources that I wanted to make sure everyone had access to. The Fenway Institute is a really great all-encompassing health research center. Many of the GLAMA, the Gay and Lesbian Medical Association, especially when it comes to provider training and advocacy, they're a great group to start with. GLSEN, GLAD, some of these more nationally recognized organizations. Of course, I have to acknowledge my study team would not have been able to produce any of this research without them. And I am happy to stick around and answer any questions to the best of my ability. So I think I finished a minute early, but I appreciate all of you being here. I haven't really been able to look at the comments that much, but thank you for having me.
So one of the questions that we got was about sexual health integration in behavioral health, and the idea of out of control sexual behavior being somewhat stigmatizing towards the LGBTQ community, and kind of what the role of sexuality and sexual behavior in mental health should be, and how that can exist in a more healthy way.
Yeah. I mean, we have to, it's going to sound so cliche and probably very overreaching, but we have to stop stigmatizing sex in general. Like, we need to be able to talk about sexual health as a part of overall health and well-being. We need to be able to do that not only with our physical health providers, but with our mental health providers. It can't just be one or the other. And, I feel like I'm probably preaching to the choir with this particular group who's on this seminar, but, it's another thing that requires a systemic change. It requires conversations in, clinical psych programs. It involves conversation in public health programs. It can't just be the, thinking coming from a public health perspective, you can't just have like the maternal and child health people talking about sexual health and public health. That's not enough. It's so not enough. It needs to be, you need to incorporate examples into the biostats classes, into the epidemiology classes, and into the general stats classes that folks have to take in psych programs and in social work. It's a lot more than that. And, there has been some work done, in the past couple, I would say last 10, 15 years, especially with my mentors and my colleagues, of showing that, it's not, gay, bisexual, especially emerging adults, are not necessarily having more sex. That's just a stereotype being placed on the community. But to the opposite effect, we're just assuming that older adults are having no sex, which is also just as problematic. So, it takes some pushing ourselves past our comfort levels. It's not always, fun or easy to think about, your grandparents having sex, but hey, you might be the one that helps them have more enjoyable sex or something like that. So, breaking down those individual barriers, but also trying to impact the systemic barriers as well is very important.
Another question we got was on the ethical issues around promoting individual resilience over pushing for a larger, more population or societal level approach to resilience.
So I don't do a lot with ethics, so I don't want to speak out of turn, because quite honestly, that hasn't even been a question that I've often grappled with. This is kind of, I wish I had a little bit more time to explain what I meant by bridging the gap between health and the health of individuals and the health of populations, because inherently, as a trained person in public health, obviously my answer is supposed to be, we have to help everyone. Like, that's the goal of public health. But what we know is that we can't impact overall health and well-being in a community or a general sense without individual change as well. When it gets harder, when it comes to something like resilience or grit or some of these more positive adaptation constructs that we're looking at, it gets a little bit harder to measure it on a community level or on a even a national level, because what is how it's not, these questions are often not being included in any of our behavioral strategy, like our BRIFISs or our NHANES. Sometimes they are, but so at times we have to figure out how we can impact the health of individuals, which then will hopefully, start to impact the health of communities. In terms of ethics, I'm stumped a little bit. I don't think it necessarily has to be one or the other, but I think both have to be synergistic in a way. Yeah.
And another question was that given that so much of resilience is based in community level support, how racism within the GSM community is being addressed and how that's impacting the health and mental health of BIPOC members of the GSM community.
Yeah, I mean, there's a lot of work that needs to be done on that. I mean, my mentor, Dr. Perry Halkitis, who's the dean of the School of Public Health at Rutgers, I feel like I'm about to steal one of his quotes, but he wrote a book that came out last year called Out in Time, where he interviewed different, I think it was 15, gay men who were across the lifespan to kind of originally just look at their coming out experiences, and it developed into this much bigger thing. But it seems like folks have this perception that people in the LGBTQ community can't be racist, and that's just as far away from the truth as possible. And I think, sometimes we think that, like, oh, because we have a marginalized identity, we know what it means to have another ethnically marginalized identity that we might have, and that's just also not true. It's not to say that you haven't experienced homophobia or challenges because of your sexual orientation, but if you are a white gay man or a white lesbian or a white bisexual person, your experience within the LGBTQ community is absolutely different and more privileged because you are white. And it takes many, it's going to take a lot of people acknowledging that. It's going to take a lot of white scholars acknowledging that, which is why I always never have a problem doing that. It takes us sitting aside and handing the microphone over, and the space is appropriate, to ensure that we're not the only voices at the table. We can't be the only ones running the HRC and the different health organizations throughout the country. And so, there has to be a sharing of that conversation. And in terms of mental health, I mean, it comes back to understanding that the mental health system is also very stigmatizing and racialized in a way that people who people who are of a racial ethnic minority identity don't have the same equitable access to mental health services, or they're more often to be labeled in some horrific stereotypical term that's very derogatory or even more stigmatizing to them. And so, there's a lot of work that needs to be done. It's not impossible. I think within any community, I think the LGBTQ community as a whole, potentially, I'm hoping, maybe I'm being way too optimistic, but as a whole would be more able to help make some of those advances than other communities would be willing to have those conversations.
Well, we've gone over by about 10 minutes now, so we're going to let everyone have their time back. Thank you so much, Kristen, for a very engaging presentation. Everyone will be emailed a copy of the slides, the recording, and information on how to receive a certificate of attendance within 5 business days. Thank you.